to start by thanking all of our team members and collaborators in the audience, as well as the person I co-lead a lot of this work with, David Ash. So the times, as Joe was saying, have really started to shift because for several years running, employers have identified employees' poor health habits as the #1 challenge to affordable benefits coverage. This is leading to pretty dramatic shifts in terms of what's happening in terms of employee benefit design, and I think create tremendous opportunities for the financing of connected health initiatives. One of the big challenges here, as others have alluded to, is what we call the 5,000 hours. So even if you have a lot of chronic diseases, you probably only spend 1 to 2 hours a year in front of a doctor if you think about the typical visit being perhaps 7 minutes. That leaves 5,000 plus waking hours elsewhere where your doctor neither really knows what you're doing nor has effective tools to influence what you're doing. And one of the great opportunities, of course, that we now face is with the proliferation of wireless devices and advances in our understanding of how to change behavior. There's big opportunities now to really change things in a way that disease management programs in the past were unable to. And I think a lot of this really speaks to the premise that technology can provide both lower cost and higher effectiveness in terms of outpatient management of chronic disease. So you need some form of hovering, and we think if you can do this in an automated fashion, you can do it, of course, with a much lower ratio of personnel. So the science of motivation has evolved quite a bit in recent years. We know that providing people with information is necessary but not sufficient. A lot of employers, as I mentioned, have really moved into the economic incentive space. About 85% of large employers are providing incentives for health behavior this year. About 20% are tying those incentives to outcomes. But the underlying limitation to what a lot of them are doing is they're really basing this on standard economics, which assumes that people are perfectly rational and really able to make all sorts of time trade-off and cost-benefit calculations to a degree that most people probably don't. So what behavioral economists have really mapped out is ways in which people are predictably irrational. People are much more focused on the present than the future. They're very susceptible to framing effects. They're very susceptible to self-control problems. They often make decisions based on how they feel as opposed to any deliberative cognitive process. And there's a long list of different areas which have been mapped out which really highlight that people behave like humans and not like junior economists. And that's, I think, has very clear implications for how you think about the interventions that can be designed. It's not just about the size of the reward. It's really about how these rewards are designed and how they're delivered. So we've been working on a concept here for several years now, which we call the Way to Health. And since this is a Penn-based program, we thought it might be helpful to give you a little bit of history. So in 1758, the university's founder, Benjamin Franklin, published The Way to Wealth, which was a guide to prosperity based on Poor Richard's Almanac. And the idea is that even back then, it probably won't surprise you, people had trouble with behaviors that were against their own economic self-interest. This is, of course, still very much true today when you look at the savings rate in the United States. But people today obviously also have problems in terms of behavior that runs counter to their own health interests. And what we're trying to do is really come up with a scalable approach to helping people change their behavior and become lower risk. This is an example of the type of approach we've used. In this case, we randomized people who were obese and had BMIs greater than 30 to different types of interventions, either a control group or a different type of incentive, a lottery incentive which provided daily feedback, or what's called a deposit contract in which people could put their own money at risk, and if they were unsuccessful in meeting their goals, they forfeited the money to people who were successful. If they were successful, we matched that one-to-one. So there's a whole series of studies we've done now in various contexts like smoking cessation, obesity, medication adherence, glycemic management, using various kinds of financial and social incentives, which show that these concepts can be very effective in improving behavior. But one of the key insights that was very clear is that actually running these interventions is pretty complicated. And so if you look at, for example, under the hood at how you run one of these lotteries, for example, we've used a lottery with an expected value of $3 a day in a lot of our studies, a 1 in 5 chance of $10 a day, a 1 in 100 chance of $100 a day. We need some way of getting inputs on what people did yesterday, which makes them eligible, and then we need some way of giving them feedback comparing how they're doing compared to pre-specified goals, and then transferring funds to them. So now we've come up with a way of automating this through the Way to Health platform. So we have a variety of different types of passive devices. We're pretty device agnostic. We just try to pick devices that are easy for the end user to use and which can passively upload information on what the patient is doing. That information gets transmitted to our server. Depending on what sort of program they're in, they get various kinds of feedback. Sometimes this is a financial incentive, sometimes it's a social incentive, sometimes there's other kinds of feedback. And then, of course, we transfer funds to people electronically as appropriate. One of the things I wanted to highlight is that this isn't just about the technology, and as the technology advances, I think the big challenge for us is really going to remain changing the behavior of people who have relatively poorly controlled disease. So if we have people who have poorly controlled diabetes because they don't take their medicines that often or they're not that adherent to their diet, if we give them a device, they're likely to not be that adherent to the device either. And that's, in fact, what you see in this graph, where the bottom line in blue shows what happens in terms of the rate of daily device uploads in a control group. You can see that this trails off steadily. It's about 50% of days by 3 months. By 6 months, it's about 30% of days. And what we did in this study is we randomized people to just having the device in the control group or one of two different types of lottery incentives. You can see the lottery incentives kept the daily device utilization rates at about 80%, and that was associated with much better glycemic control in those groups than in the control group. So there's a lot of different programs that we're running now with partners around the country, looking at areas ranging from smoking cessation to obesity, a variety of approaches that we think can help make various population-based financing programs more effective, various medical home 2.0 initiatives, a number of programs around medication adherence. And there's some interesting tests here. One of them we think is the first test anyone's done of a patient versus a provider incentive in terms of lowering cardiovascular risk among people with poorly controlled cholesterol. We're also doing work on deploying these concepts now in the context of people who have been admitted to the hospital with heart attacks and using a combination of financial and social incentives to try to lower their hospital readmission rates and subsequent costs. A lot of this is really, I think, going to explode from the standpoint of more money being driven through the system. So there's a big provision in the Affordable Care Act, which I think has been underappreciated to this point. Section 2705 is going to allow employers to use up to 30% of premiums for rewards or penalties tied to outcome-based incentives. They can be up to 50% if it includes smoking. So suddenly we have the potential that employers in the health benefits space, which is a hundreds of billions of dollars a year market, will be using a lot of that money to either reward or penalize employees based on their BMI, their blood pressure, their cholesterol, and their smoking status. And that has the potential to really drive a lot of further innovation in this space. We are concerned, though, that if this is just done as a premium adjustment, it's not going to be all that effective in changing behavior. I think one of the clear things that we've all learned from behavioral economic research is that the feedback frequency is really important, the type of feedback delivery, how it's delivered, how salient it is. That's going to have a really big impact on whether these programs are effective in changing behavior and don't just result in shifting costs to higher risk people. So here's where we hope that we'll end up. In 2013, we're still living in a world in Philadelphia, maybe not in Massachusetts, which is still primarily a reactive visit-based model. Healthcare financing here and in much of the country is still based predominantly on fee-for-service. Telemedicine in many cases is still fairly rudimentary. It's heavily personnel intensive. There isn't that much or as much as could be done in the way of automated algorithms. And patient engagement is often not that high because people haven't really combined social science engagement approaches with the technology. Where we think we need to go is really moving to more of a proactive non-visit based model in which health financing increasingly will be based on bearing risk for populations. And then I think we can move to a vision which really includes automated inputs to providers, automated feedback to patients, various types of engagement strategies that can really help us make higher risk patients lower risk.